Thanks for coming to the respiratory. So today we'll be going through SBAs. So we'll cover SBAs and ABGs, and then at the end we'll go through some chest X-rays, like sort of OSCE style thing, and then we won't be doing the RESP exam and like the ABCD stuff.
Stop sharing.
Oh yeah. No, it's not here anymore. Sorry. Can you move it to the other page? Wait, should I just do it on your laptop?
Can I stop sharing for 1 second? Can you just like give you my laptop?
Yeah, sure.
So that I can just say what I need.
Yeah, thank you. Yeah, and then so we're not covering that Dr. ABCDE and also prescribing, so that's for another tutorial. And then sorry, you can't see the screen right now, but we'll get it back up. So far you guys have still got like a month, more than a month left, I think, till exams. You've got loads of time. Top tip, just try and do some OSCE practices like with the people. Probably from now on will be a good time. So we'll go through some core conditions. We've got lower LRTIs and ERTs, so upper respiratory tract infections, and lung cancer, pneumothoraxes, pulmonary hypertension, respiratory failures, both type 1 and 2, and sarcoidosis. These are the kind of core conditions outlined by UCL. And then, yeah, so all the SBAs we'll be presenting today are not past UCL exam questions, so just to let you know. Okay, so we've got SBA number 1, which I'll try and share. I'm just gonna get it up like as a share. So yeah, can you guys see that? Where's the code for the Mentee?
Yeah, I think the Mentee will come when the first Mentee slide comes on, I think. Like the actual...
Is there a code for them to join it?
Yeah, there will be when the first question
okay,
comes up. Yeah.
Wait, but the code was on the answers.
No, like it'll come up now, yeah. So then that's fine. See what I mean?
Okay, so we'll give you guys... Yeah, but what's
the question? Is that can't 6466042? Wait, are you?
Yeah, they record it automatically. Oh, okay, you're presenting now. Can I use your laptop? Sorry, guys, for the technical issues. Okay. So the Mentee code is 6466042. If you guys want to join that, and then get your answers, and then I'll go back to the page now so you can see the question. And we'll go through it in sorry. Okay. So let's see. Oh. Any answers? Well, okay, we'll just go through it anyway. So The answer is C, alpha-1 antitrypsin deficiency. So the key things to look at here is, I would say, is the yellow tinge on the skin and the liver function tests together with these wheeze and crackles. So when you see a question where they have so how do I do that? Oh yeah. So this is a inherited disease. I think it's autosomal recessive. And basically what happens is there is a neutrophil elastase that breaks down, which means in the lung they have emphysema. And they also have neutrophil elastase in the liver, which normally that's where it's made. So that's why the liver is affected as well. So investigations wise, you do some blood tests to check for A180 concentrations, to chest x-ray, pulmonary function tests, and liver ultrasound. So because it's a genetic disease, you'll do some genetic testings to check the genotype. And then on spirometry, you'll see a obstructive picture. So management-wise, a lot of it's supportive, bronchodilators and physiotherapy, and tell the patient to stop smoking. So when you see like a young patient with COPD kind of picture, so emphysema and things, and they don't smoke, then think A180 deficiency. You can also give them IV alpha-1 antitrypsin protein concentrates. So the next question, SBA 2. If you guys could join the code again, if you can, and answer the question. So it's 64660442. And I'll give you guys 30 seconds. Okay. Okay. Oh, great. Okay. So let's see. Isn't working. Wait. Oh, there we go.
Press H to the responses.
Oh, yeah, here we go. Okay, well done for those who've got life-threatening. I see why people go for severe, because I would get tripped up on this as well. So in terms of the symptoms, you're right, it's pointing more towards severe because PFR is 40%, and as you probably have remembered, it's 33%, I think. But you need to look at the PaCO2. So the PaCO2 is normal, which classifies this as a life-threatening asthma attack. And the reason for that is, so in asthma, people should be hyperventilating, and people going like very fast. So the PaCO2 should normally be below 4.7. And if it gets normal, that means they've started to get really tired out. So their respiratory workload's decreased. So that's why it's life-threatening. In this case, you should probably start contacting the ICU team. Okay, so this is a, where's it, COPD? Okay, we'll go through COPD. Why can't I go through? Something. Oh, here we go. Sorry. Everything's a bit. Okay, let's go through asthma. So this is probably a page you guys have seen on PassMed. It's something you just need to remember. And also in the life-threatening, as I've mentioned before, if the PaCO2 is normal, then that's also a sign that it's life-threatening. So acute asthma, always remember salbutamol to start with. And then this is nebulized as well. And you add ipratropium bromide later on if it doesn't respond to salbutamol. And steroids always give with salbutamol at the start, and then continue prednisolone afterwards, so oral prednisolone. Okay. And these are the little criteria to refer for intensive care. So hypercapnia is in here, but I think for if they have normal PaCO2, then you should consider or at least contact them to prepare for them to become hypercapnic. Yeah. So diagnosis-wise, you should do a FeNO test and also a spirometry. And these are just some numbers that you have to remember. So above 40 and FEV1 divided by FVC ratio less than 70%. So this is an obstructive picture, same as COPD. And you should do a reversibility testing, which is when you give them some salbutamol, and then if their FEV1 improves by more than 12% or by 200 milliliters, then that's a positive test for asthma. And then this is just a long treatment plan that you should probably remember, but to be honest, I don't think we've been really tested on it so far. Not past level yet. So like to start, yes, but beyond that, I've never really seen actual questions on them. So I wouldn't get too obsessed with that if you can't remember it. Okay, so SBA 3. Give you guys 1 minute. Okay, so go through that. Right, I don't know if I'm pressing this correctly. Okay. Okay, so SBA 3 is on pneumonia. So the key things to think of here is the curve score, but without the U because you're in the GP. So he's 68 years old, and his respirate is above 30, and he is got a blood pressure of 170/59. So because he's got the age and the respiratory rate as well, I don't think he hasn't got any confusion. So that's Cormoxclav plus clarithromycin. So he's got the COPE 2 score. And you should, I don't think they'd ask questions as to where you're going to admit or not, because with a COPE score of 2, then it's, you know, a clinical judgment, which you can't really tell on an SBA. So just remember the antibiotics that you need to prescribe. But if it's a COPE score of 3 to 5, so if they additionally they've got any confusion or low blood pressure, then you need to admit them from the GP. Okay. So how does pneumonia present? So if someone comes in with fever and fast heart rate and reduced O2 saturations, or breath sounds are reduced, there's dull percussion, and they're coughing, they've got a history of sore throat, and they're feeling really fatigued, you need to think immediately pneumonia, especially for older patients. And then you should calculate the COPE score. I think that came up in an OSCE in a previous year, not in our year. So okay. Good thing to remember. And then SBA 4. I'll show you guys the code again. It's 64660442. Oh, it's in the chat. Okay. So the answer is arrange immediate hospital admission. So this question seems quite similar to the other one, but this time the key is to recognize that this person has got sepsis. So how do we know that? They've got worsening shortness of breath, productive sputum. This is classic pneumonia picture. But then the key thing to note is the respiratory is increased, so it's above 20, and the blood pressure is borderline low, and the fever is very high. So with someone who's 35, you wouldn't really expect them to be so like systemically upset with just the pneumonia. So this points to a sign of sepsis. So this is a very big thing to look out for in both SBAs and OSCEs. So if you find someone with altered mental status or really fast respiratory rate, low blood pressure, think immediately sepsis, and remember the sepsis 6 really well. So 3 in and 3 out. The in is antibiotics, IV and IV fluids and oxygen, and 3 out is the blood pressure, blood cultures, lactate and urine output. And this is quite a good thing to remember for OSCEs as well, for like an ABCDE, the sepsis 6. and it should be performed within 1 hour of hospital admission. So SBA 5. Okay. Okay. Very good. Well done, guys. So the key thing to recognize here is they've started a drug that was prescribed by a rheumatologist for rheumatoid arthritis, and the bibasal and inspiratory crackles. So it's at the base. That's a key thing to note instead of being at the top. So fibrosis is a good mnemonic to remember is charts. So these are the upper lobe fibrosis. So core workers pseudocytosis, sorry, I literally don't know how to pronounce that. And also ankylosing spondylitis, radiation's a good one to remember, and sarcoidosis is quite key as well. And then I would say if you remember those, and then the ones that are not in it would be in the lower lobe. Someone said that, for example, asbestosis, you remember it like it would be quite a heavy thing so that it would fall down towards the lower end of your lungs. So methotrexate, sulfasalazine, cyclophosphamide, and penicillamine and gold. These are all the drugs that would cause lower lobe fibrosis. So classically, the patients would present with dry cough and exertional dyspnea. And you would see fine end inspiratory crackles and clubbing because the oxygen would be quite low. And important thing to remember is the diagnosis is with a CT. So you do the chest X-ray first. You need to do a CT to check for ground glass and honeycombing. These are big buzzwords that they like to use. And a spirometry is a restricted picture, so that means the FEV1 and FVC is both reduced. So the ratio would be above 0.7, unlike COPD and asthma. Management is really limited. So treat the underlying disease and stop the drug. So for example, in this case, you'd stop the methotrexate. Pulmonary rehabilitation. And NICE also says these two drugs, pirfenidone and nintedanib, but I think they don't work that well. So the key thing as well is the idiopathic pulmonary fibrosis, which commonly presents in elderly men, and they come in with fine end inspiratory crackles and clubbing. You think that's fibrosis. I think the clinical picture is quite bleak, like average 3 to 5 years. Okay, so okay, I will hand over to Deena, if that's okay.
I share my screen then, or do you? I don't mind if you want to keep
that's
clicking
okay.
through. Oh yeah, that's fine. Can you see that okay, or is it not full screening?
Is the present not working either?
I don't think so. It's not full screening, is it? Every time I do it. Let's try and do it.
I presented first and then shared my screen, and then that seemed to work for me.
Okay, let me try that. Yes, I don't know. Yeah. Okay, is that okay now?
Yeah.
Okay, super. Okay, so yeah, just to continue on. So yeah, next question. Again, just put it in Menti. 32-year-old obese woman presents to Amy with sudden shortness of breath and pain when she breathes in. She says she has also coughed up a small amount of blood. Oxygen sats 88% on room air. You look at her notes and see that she's recently been discharged following a hip replacement. Her ECG rhythm strip is shown below. And given the likely diagnosis, what is the most appropriate initial management? Okay. I'll go. The CTPA, oxygen. Okay. Anyone wants to keep voting? Okay, so kind of split between these two. And these two definitely would be the most likely answers. So the correct answer is actually oxygen. So this is really because of the way the question is written. So you can kind of identify that a P is most likely what's going on here. And normally, yeah, gold standard is the CTPA to diagnose and then decide management depending on its size and where it is. But what's important here is that they've asked for the appropriate initial management. And so you're going to be thinking about this question in a more of an ABCDE approach. And the most sort of imminent issue and pressing issue is actually that this lady's oxygen saturations are at 88%. So the first thing that you need to do is give her oxygen, high flow oxygen, to get her sats a bit more normalized. So whenever you see a patient like this in any emergency situation, you're thinking ABCDE first. There's a lot of questions like this as well on PassMed, and yeah, it just catches you out if you're not thinking about initial management. If they'd said like the gold standard sort of investigation or something like that, then yeah, CTPA is good. So yeah, hope that makes sense. So a little bit on PE. So thinking about some risk factors here, we've got a mnemonic, and it's quite helpful to know them because it helps when you're reading the question, identifying what's going on. So in the last question, yeah, so she's got sort of an increased BMI, and then coming in with this sudden shortness of breath. She's had a history of surgery, and quite a big surgery. So these already give us some risk factors, and then she's also got some classic PE presentation. When you're thinking about diagnosing and what to do next, it's really between this, whether we CTPA or do a D-dimer, and we use the Wells score to figure out what the sort of probability is of a PE. So really you're working on likelihood of PE and therefore what you do next. As you can imagine, it's an emergency. So yeah, you're working on sort of likelihood. So yeah, know this relatively well. That's quite helpful to learn. Again, questions might present in that way as well. So yeah, your chest X-ray is your initial investigation. Most likely will also have an ABG. Whenever there's a low oxygen sat, it's always really an indication for an ABG, and it might show respiratory alkalosis. And then your pulmonary angiography is your gold standard, or CTPA. The ECG, which is on the other the part of the question as well, has sinus tachycardia. So this is actually the most likely ECG you're going to see with a PE, although in the textbooks you learn the S1, Q3, T3 pattern. It's actually really rare to see in real life, and really it's more likely to be a sinus tachycardia. And then in terms of management, so DOACs are really the first line now. They've really revolutionized sort of PE, like clot prevention, and only in severe renal impairment do you consider low molecular weight heparin or warfarin. And then there's some contraindications as well for DOACs. In pregnancy, DOACs are contraindicated. You always use low molecular weight heparin. And so, yeah, so these are the same antiphospholipid syndrome, you'd use warfarin. So these are the kind of main bits that you need to remember if you're thinking about management. Okay. So moving on to SBA 7. 52-year-old lady presents with a 4-month history of a productive cough. The sputum is yellow, green in colour and occurs most days. She was given 2 courses of antibiotics by her GP. However, they've not seemed to have helped. She's got a past medical history of hypertension and pertussis in 2008, and she's otherwise well, and some social history there. So she drinks 10 units a week, smokes socially, it's not since, and on examination, coarse inspiratory crackles bilaterally. What is the most likely diagnosis? Okay, let's have a look. Yeah, so that looks very promising. So yeah, bronchiectasis. Yeah, the right answer is bronchiectasis. Correct. So yeah, you've got sort of one of the classic histories that could work for bronchiectasis. So bronchiectasis is this permanent dilation of the airways. You get this poor mucus clearance, and then that's going to give you a greater risk of infection. And then there's a further inflammatory process, and it's a vicious cycle. And so this sort of classic long-standing history of a productive cough, and then the 2 courses of antibiotics doesn't seem to help. So it's this consistent infection that doesn't seem to be going. It's quite classic of bronchiectasis. And then on top of that, she has this history of pertussis or whooping cough, which is a risk factor for developing bronchiectasis and causing that sort of dilated airway in the first place. Then the course in respiratory crackles bilaterally as well. It's a classic examination finding for bronchiectasis. So, yeah, some of these symptoms, which kind of goes with the pathophysiology of these dilated airways and this really bad mucus clearance, which is going to result in sort of these recurrent respiratory tract infections. And we've talked about the respiratory crackles, but also clubbing and wheeze are other signs you might find. In terms of the infections that those with bronchiectasis are more likely to get, Haemophilus influenza is the most common, but all these other sort of more atypical infections are likely to present in bronchiectasis. So yeah, when you're thinking productive cough, it's not getting better with antibiotics, bronchiectasis, and yeah, just thinking of some causes. So you can have the congenital causes with like cystic fibrosis, and primary ciliary dyskinesia, and then more commonly actually it's idiopathic, and then infections like pertussis or COPD. Okay. SBA 8, 70-year-old Bangladeshi lady presents to her GP with shortness of breath that's been present for the last 3 months. She's also coughing up some blood. What is the most appropriate initial management? And let's have a look. Okay. So mostly or on 2-week wait referral, and that's correct. So this is quite a classic suspected cancer presentation, especially just because they're coughing up blood. So hemoptysis is like one of the key sort of signs or symptoms that you would immediately 2-week wait refer to rule out a lung cancer, especially if they're not presenting with any systemic symptoms like no fevers or that's like a cold that's then like kind of got really bad and they've been coughing up some blood, but she's had this shortness of breath for the last 3 months. Of course, like they can have systemic symptoms related to the cancer, so like fever and weight loss. But yeah, naturally, if someone came in with a fever and that's just like a history of like other symptoms more associated with an infection, they might say that they're coughing up some blood. So you want to differentiate, between an infection that's been a bit persistent and maybe some like injury or trauma from the infection from coughing, compared to this, which is very obviously a long-standing issue with her breathing, and then she's kind of presented with this complaint of like something's changed and I'm coughing up blood. So yeah, your 2-week wait. So with the 2-week wait for lung cancer, they're going to have an X-ray. So that's the kind of thing you would explain to them as well in the appointment. And from there, people are assessed, and then if there's anything that's seen, then most likely they get CT. And yeah, some other unexplained symptoms as well. So if they have just fatigue, weight loss, appetite loss, these are all indications for 2-week wait as well. And a smoking history is quite an important aspect as well of forming that plan. So a bit about lung cancer. So when you're taking sort of a history and you're thinking about risk factors for lung cancer, you really want to make sure you're getting an accurate smoking history. Ask about how much they smoke per day, etc., to work out your pack years. Occupational history is really important. Can mean that some cancers are more likely than others. And then air pollution, any family history of lung cancer, and any previous scarring to the lungs, so any chronic infections, COPD, things like that. And then slightly cut off, but yeah, you've got some of the features of lung cancer, so kind of what we were talking about before, the persistent cough, hemoptysis, dyspnea. And yeah, so then initial investigations we said would be chest x-ray and then your contrast CT to look for any METs as well. And thinking a bit of management, which you've probably covered a bit more in your cancer patient pathway as well, but thinking about sort of basic management for small cell lung cancer and non-small cell, with small cell being more chemotherapy, radiotherapy, and palliative. It's not a great outcome, and non-small cell, possibly lobectomy with a curative intent. So, and then some adjuvant therapy, radiotherapy if needed, and chemotherapy. We can divide lung cancer into small cell and non-small cell. And your small cell is about 15%, it counts for about 15%, often worse prognosis. And the non-small cell, which can be divided into your squamous, adenocarcinoma, and your lung cell, large cell lung carcinoma as well. With the small cell lung cancer, we've highlighted here like Cushing syndrome and Lambert-Eaton syndrome. So those like commonly present in questions. There's a history of some kind of Cushingoid symptoms, so like their round face or the hump or striae, and it's getting you to like decide what diagnosis is more likely or what type of lung cancer is more likely. So you're thinking small cell, and same with the Lambert-Eaton syndrome. So if they've kind of presenting with like loads of fatigue, muscle aches, etc., then you're thinking small cell as well. And then with adenocarcinoma, gynecomastia, another common presentation on the side of all the other lung cancer symptoms, which would lead you more to think about adenocarcinoma. Okay. SBA 9. So an 88-year-old woman in A&E received a chest x-ray, which is shown below. The patient underwent a pleural fluid aspiration under ultrasound guidance, and the fluid shows a protein content of 37 grams per liter. Which of the following is the most likely underlying cause of this lady's pleural effusion? So I'll give you a few seconds to answer, and then I will share the responses. Okay, great. So malignancy, correct. So we're thinking here about pleural effusions and differentiating between exudates and transudates. So to go into a bit more detail, your exudates are any protein levels over 35 grams per liter, and your transudates are less than 25 grams per liter. So in this previous question, essentially malignancy is the only option in the exudates, so over 35 or 37 grams per liter. So this is one of those ones that you just want to know the cutoffs and the reasons for it. So when you're thinking of exudates, it's this fluid buildup because of tissue leakage, so due to some kind of inflammation or local cellular damage. So that's why you have malignancy, infection, inflammation. And then with your transudates, you're thinking of a systemic condition that alters the pressure in the blood vessels. So then you're more likely to think of like some kind of organ failure, endocrine failure like hypothyroidism, and most commonly sort of seen in heart failure. So kind of remembering the cutoffs and the reason behind an exudate or behind a transudate, and then working out then which one is there. So those questions are always, there'll only be one of the exudate or one of the transudate, and then that's the answer, but you just need to know, which ones are which. And then just generally about pleural infusion. So on examination, that stony dullness on percussion. Again, the symptoms quite non-specific, kind of can be similar to other respiratory presentations. But the stony dullness is quite characteristic of the pleural effusion. And then really you just want to image and see it on the chest x-ray, and there's a lot more chest x-rays later on. You can have some practice of that. Potentially a contrast CT if you want to find out a bit more about the underlying cause. In the case of the malignancy, it would be a good indication for a contrast CT to see the mass, to see any metastasis. And then most patients with pleural effusion will have some kind of pleural fluid sampling as well, especially if there's any kind of infective cause, to culture and allow drainage as well of the pleural effusion. Okay. So another really helpful little textbooks here, little table about x-rays. So whenever you see a white out sort of lung, so like this picture here where the whole one side is white out, there are a few things you're thinking about, mainly where the trachea is. So if we look back to this x-ray, we can see that the whiteout is on the right hand side and the trachea is being pushed away from the whiteout. So that makes us think about this side, the right side of this table, pleural effusion being quite high up on there. Large thoracic mass, you would most likely see some kind of shadowing of it. And then the diaphragmatic hernia as well, you might see it above the diaphragm. So trachea central, you're thinking more infection causes, consolidation, pulmonary edema, and then towards the trachea being pulled towards some kind of pneumonectomy or complete lung collapse. And then on examination, your dull percussion is kind of collapse or pleural effusion, but the stony dullness is more like indicative of pleural effusion. Okay, SBA 10. A man is brought to A&E unconscious. He has low blood pressure, low glucose. You're very concerned and call the anaesthetics registrar, who asks you to perform an ABG. And these are the results of his ABG. What is the most likely cause of his metabolic profile? Let you have a look at the ABG and then try and remember which one you want to answer. And go ahead. Okay, so we're quite split between all of them. This is quite a tricky question, I think. So the right answer is Addisonian crisis. So we'll go through this. So you've got your ABG, and what you're thinking about here is your anion gap. So working out your anion gap is your sodium plus your potassium minus your chloride plus your carbonate. So if you do the calculation, okay, so it's like 137, 29. So it's like 7, 8 is your anion gap, which normal, this is like relatively normal range. It's not a massive anion gap, 10 to 20 being your normal. So from that ABG, you get to know that it's a normal anion gap. And then we go to think about the causes of that. And actually, there's only one in that list that's really a cause for it, which is the Addisonian crisis. The others are all a high anion gap, with DKA sometimes presenting with normal after treatment, but most likely it will be in a high anion gap. So that's the main reason we're thinking of Addisonian disease and an Addisonian crisis. The other thing is these questions with Addisonian crisis tend to present as well with this hyponatremia, hyperkalemia, and hypoglycemia. So there's this trio in the Addisonian crisis. So you've got your low glucose, your high potassium, and your low sodium. That also kind of draws us to think about Addisonian crisis. So two things that you have to think about: your anion gap, and then also look out for, especially when they give you the glucose, low glucose, you're thinking Addisonian. That kind of, removes DKA anyway. So metformin, vomiting, and paracetamol are all in your high anion gap metabolic acidoses. There's a lot less for the normal one, so they're quite easy to remember. So if you remember these normal anion gap causes, then really everything else is high anion gap. And most commonly, the ones that you'll see for normal is the Addisonian crisis or GI losses. So those two are the main two to remember for normal. Okay. Awesome. Okay, so that's my bit done. So should I give it to you now?
Yes, please. How did you manage to get to present it? Because it worked for me before, but now I'm not so sure it's working.
So I did the same thing. I presented, so I did it as the present the whole thing, and then I escaped just so that I can access the Teams meeting still. But when you share it, it does work. Even if you can on your own screen, you can still see the like bit on the top. If that makes sense.
But it's not like the present button is not letting me present. Maybe if I refresh the page.
If not, I'm happy to just go through it with you. This
should work now, maybe. Oh no, it showed up for a second and then disappeared again. Have you ended the presentation like on your end?
it's still in the same place, so I can just share it again.
But I'm saying if you just like end the presentation and then because
I see. Okay, fine. Yeah.
Two people can't present at the same time or something like that.
That's possible. 1 second.
Yeah, I think that is the issue.
I'm just going to X out of it now. Should be okay.
Okay, can everyone see this?
Yeah, can see that.
Correct. Okay, so this is the next SBA. Well, technically the final official SBA which has like a topic related to it. And so thin, young, 19-year-old presents to A&E with sudden difficulty in breathing. On examination, he has hyperresonant chest with decreased lung sounds on his right-hand side. His trachea is deviated to the left. Given the likely diagnosis, what is the best initial management? Deena, just to check, is the poll automatically open? Or do I have
so when you go to the next slide, then the poll will open, and then give it a couple of seconds, and then you can show the responses.
Yeah, I think that's probably as many as we've got. Okay, so that's correct. The majority needle decompression in the second intercostal space. Reason being that this is a tension pneumothorax. Reason that you know that this is a tension pneumothorax and not a spontaneous pneumothorax or otherwise is due to some of the kind of giveaways in the brief, which include thin, young, 19-year-old. That's kind of your typical presentation for a tension pneumothorax, or for a pneumothorax generally. Then hyperresonant chest and decreased lung sounds in your examination. That's obviously why you need to always check. This will probably be in an A to E situation due to the fact that you're in A&E, sudden difficulty in breathing, not gradual. And the big telltale is the trachea being deviated, and that will only happen in a tension pneumothorax and not in a spontaneous pneumothorax. That can also be shown in a chest x-ray, which is here. We'll go through a bit more on chest x-rays, but to start with, chest x-rays regarding pneumothorax. So we've got two chest x-rays here, and which show different types of pneumothorax. So as you can see here, the trachea is deviated. Can you see my cursor? Just checking. Deena?
No, I can't. Oh yeah, I can see it. Yeah, it's fine.
As you can see here, the trachea is deviated, and there is complete loss of lung markings in this entire left lung. And this is actually the lung itself. So this is quite a tricky chest x-ray, and one that I think I've seen people last year get tripped up on quite a lot, because of how small the lung is on this side, that it almost looks as if it's just a continuation of one of the heart border. But if you look closer, you can see that there is absolutely no lung markings in this side, and it's it's like a lot darker, meaning that it's a less dense area of the x-ray, hence suggesting that there is no lung there. And if you look at this one below, can anyone put in the chat what kind of where the pathology is on this chest x-ray? Just sort of submit it as a question. In the Q&A box. Okay, good question. I was trying to look this up, actually. I was a bit confused about this myself, about the guideline updating the position for the needle decompression, but I thought second intercostal space was the updated version on my research, but if I'm wrong, I'm so sorry. Deena, do you have any input on that by any chance?
Yeah, actually, I think on Coop they were saying that it might now be mid-axillary line, fifth intercostal space.
Okay, then I apologize for that, because
I'll just double check it as well, but sure. Yeah, I'll come back to
yeah, okay, yeah, get back to you on that one. But yeah, sorry about this. These slides are kind of old, so maybe that's why. But yeah, main thing to note that it will be immediate needle decompression. This is a clinical diagnosis as well. So even though I am showing you a chest x-ray here, it's very unlikely that you will see many chest x-rays. But having said that, in practice, doctors do say that sometimes they do a chest x-ray just to make sure that what they're diagnosing is correct, because in reality, getting an immediate chest x-ray won't take that long. But for exam purposes, for OSCE purposes, A/E purposes, immediate needle decompression, as you're saying, probably in the 5th intercostal space, mid-axillary line. That diagnosis will be done with percussion of the lung fields, which will be hyperresonant, decreased breath sounds, and tracheal deviation. And that is enough for you to diagnose a tension pneumothorax. Did anyone answer me about my second question about where the pathology is on the bottom chest x-ray? If not, that's fine. So best way to find out what's going on in chest x-rays when you're suspecting a pneumothorax is completely trace the pleura. So as you can see here, there's a slight loss of lung markings right over here. And that's very subtle, but that's likely to be a spontaneous pneumothorax. And so spontaneous pneumothorax tends to be due to things such as like malignancy, asthma. I think basically just obstructions, whereas tension pneumothorax tends to be due to trauma of some sort, essentially. And yeah, just important to know the symptoms, which are similar in both, but in tension pneumothorax, it tends to be like a lot more sudden, so sudden breathlessness, sort of like shock symptoms as well, so tachycardia, low blood pressure, and yeah. Okay. And then here is a sort of flow chart of your management of spontaneous pneumothorax. So you can have primary or secondary, and that kind of changes your type, your like chest strain versus just high flow oxygen and observation, essentially, because some of these will just resolve on their own. So on the topic of, sorry, I'm just really struggling to work this Mentimeter. Okay, on the topic of chest x-rays now. I wonder if anyone would be willing to unmute and present this chest x-ray to me. It's good practice for OSCEs, very good practice for OSCEs. But if not, that's fine. Guys, 10 seconds if you want to. Okay, no worries. So I know this is an SBA tutorial, but I just thought it's important to like run through a presentation of a chest x-ray, because the format of presenting a chest x-ray will also make sure that you hit all the areas. And so when you're looking at a chest x-ray in SBAs as well, you're going to be very unlikely to miss something very important. So as I'm sure all of you know by now, the method of going through a chest x-ray is Dr. A, B, C, D, E. So that's starting with patient details, which obviously in an SBA is not necessary, but just a note, even sometimes in OSCEs, maybe they don't make the patient details clear, or they don't include them. In a UCL OSCE, it's very unlikely that they won't include them, but even when you're practicing OSCEs and there aren't patient details provided, just make a habit of still saying, I would check the patient details, their name, their date of birth, the time at which this X-ray was taken, and the indication. And just say that every time you're presenting any results, any patient results. Then R is ripe, so rotation, inspiration, penetration, and exposure. So make sure to note those as well. Not as important to note those in SBA either, but it kind of contextualizes your X-ray, so consider that anyways. And then you go airway, then your lung fields, your heart borders, your diaphragm, claustrophrenic angles there, and then just generally having a look all around, so looking at the bones as well, because that they might show you a chest X-ray, difficulty breathing, but it's actually like something wrong with the vertebra, for example. So also in the SBA, they might expect you to know upper lobe, middle lobe, lower lobe on a chest X-ray. In an OSCE setting, they might not do. So I would stick, because it's not going to be very clear all the time. So I would stick to saying upper zone, middle zone, lower zone when presenting a chest X-ray in OSCE settings, unless you're absolutely 100% sure. However, there are some signs that can tell you if it's upper lobe, middle lobe, lower lobe in chest X-rays for lung collapse. So a few more SBAs here. These will be fairly quick fire. Oops, I gave away the answer there. But in case you didn't see that. Okay. So these are just some quick fire things that you should just know. Like, it's very unlikely that you'll be tested on these, but just like some simple X-ray signs that you can know just to help you out and quickly diagnose things. So this is a Sale sign in left lower lobe collapse. And yeah, this quite clearly demarcates what we're looking at here. So you kind of lose your heart border a bit, and you kind of have like a right angle here, like it becomes basically very triangular, like a sail. So that will be a left lower lobe collapse. And then that.
Just to let you know, I have a bit of information on the tension pneumothorax, but we can talk about it at the end.
So thank you. Sorry, I didn't realize I haven't opened the Menti there. So if you want to just quickly pop your answers in. in case you forgot the options. A was left pleural effusion, B pulmonary edema, C left upper lobe collapse, D left lower lobe collapse, E hilar lymphadenopathy. I think we only have 3 people, so I'm going to show the answer now. So well done to that one person, but don't worry, this is a difficult one. So this is the veil sign, and essentially, as you can see on this side, it just looks like a veil has been laid over the lung. And yeah, again, just something that you need to know. Well, I wouldn't say need to know, but like it's useful to know just for like quick diagnoses that can help you in the rest of your SBA. I don't think you're really going to get like spot diagnosis of x-rays like this, but it can help you with your SBA and just knowing what's going on and having a better idea of the context of the question. Any more answers for this one? You're going to close the poll on this one. Well done to the majority here. These are tricky, by the way, to just spot diagnose, so don't worry, and that's why we're going through it, just so you have a better idea of some of the signs. So this is a right middle lobe collapse, and you can tell that by the loss of cardiac border, as you can see, kind of just blends into one white mess here, and that is a sign of right middle lobe collapse. And you may have spotted the theme by now. So let's have a go at this one. Okay, nice. Well done, everyone. That is correct. So I assume all of you can see here, there's like a loss of diaphragm border here. It should like kind of be sharp, a bit low, well, first of all, lower, and shopper. Here. Just going to close it there. Well done. And here. Golden S sign. I'll be honest, I didn't know this at all. But just again, something. If you've seen this one X-ray before, then that's kind of enough to recognize it again. So just remember this sort of S sign here, and that should be fine, to be honest. I guess you got like a bit of a whitening as well. You know, like you can kind of see that. Oh, sorry. That is like something is wrong in this upper lobe. Okay, and now I've got a spot diagnosis for you guys. So can you put in the chat that I think? I'm going to enable comments. Maybe you could put in the comments here. But I don't know where to find these comments. Okay, maybe just put it in the Teams Q&A chat.
We've got renal tumor metastasis in the Q&A.
Yes, essentially, yes. So name for this is cannibal metastasis, which is basically hematogenous spread of disease in renal cell cancer. So yeah, that's correct. Well done. Okay, now again, if you can just put in the chat what the pathology is here, and if you can give some differentials, but mainly what the pathology is. Let's start there. And again, as I said before, remember to sort of like trace all the borders, look at everything in the X-ray. And you should be able to find pathology. Anyone else wanna make a guess? Bilateral hilar lymphadenopathy, that is correct. So that is here. Hyperexpanded lung fields, maybe a little. With hyperexpanded lung fields, you might also expect like slight flattening of the diaphragm, which the diaphragm seems pretty intact here. But what you can see is bilateral hilar lymphadenopathy. So that is what that looks like. So again, familiarize yourself with x-rays that have that, because that is a bit of a tricky one to spot sometimes, because it's not always obvious. It kind of sometimes just looks like regular lung markings, but as you can see here, it kind of has that like lymphatic sort of shadowing, and so bear that in mind. Anyone have any potential differentials for bilateral hilar lymphadenopathy? Maybe like 10 seconds. If not, we'll just move on, because I'm sure all of you are tired now. Very good. Sarcoidosis and TB. In the context of just general medicine, also lymphoma. So if you were to see this x-ray, you might want to do a sputum culture as well to check for TB. Obviously, you'll be taking a history, so that will be making it a bit clearer as to what your next step in investigation and management is as well. Okay. What is the pathology that you can see here? And just put that into chat again, give you like 20 to 30 seconds to try and find one. Okay, so kind of see why you might say sarcoidosis because of this like increased shadowing, but I think that might just be a little bit unrelated. So the pathology here is actually a mass. I think it's outlined better here. Here we go. A mass in this area. And this is again why I say trace all your borders. That includes your heart borders, your pleura, down the airway, fully following your paths. And you know, if you trace everything, you will see like, oh look, there's something a bit strange there, a bit hyperdense. So that's how you would find in mass. But yeah, these are tricky x-rays. Best way to like familiarize yourself with x-rays more is to just go onto Radiopedia, search every breast condition you can think of and look at all the x-rays. I think Radiopedia might even have like these, I can't remember what it was, but if you just search like x-ray quiz, that was really useful as well. I'm pretty sure I did quite a few of those before my SBAs, before my ASCIIs even, just to like be able to like spot diagnose x-rays, and you know, you don't have to think about them that much when you come to SBAs and ASCIIs. Like as soon as you look at something, you can find the pathology. So I would definitely recommend you do that. So that is the end. So this is a QR code for feedback. And then Deena, do you want to share your information that you found about the pneumothorax whilst you guys do that?
Yeah. So I think the thing with the tension pneumothorax is essentially the evidence is not like as solid anymore for the second intercostal space. It's kind of like conflicting evidence, but it's more because you have to consider the patients who are like obese or have a lot of pectoral muscle mass, and really then like your fifth midclavicular line like is going to probably be more likely like a better option, and like maybe like even first line. PassMed still says second intercostal space, as does QuesMed, and it's not wrong to do second intercostal space. I think medical school is still kind of going with that, but you're going to hear it on the wards a lot more that like fifth the fifth intercostal space is axillary line is like more, it might be thought about and might be a point of call to like think about, and you have to just be a bit more individual to the patient rather than always doing the same thing. And apparently the evidence says that like up to 50% of trauma patients, the second intercostal space won't work. But I think for the sake of your SBA's tension pneumothorax, stick to second intercostal space. That seems to still be the medical school guideline. Hope helpful.
On that note of kind of updated guidelines and such, in the slides, third line for asthma management, it said, let me find the slide actually. This might be something that you've come across with on replacements and such. So third line here, it does say LTRA with your low dose ICS. However, there's a bit of confusion about this because UCL like to follow BTS guidelines where they can when it comes to rest conditions. And BTS 2019 guidelines, I think it is, says you would add a LABA third line. And that is preferred. However, on PassMed, it does say LTRA because they follow the NICE guidelines of 2017, I think. But UCL would prefer you to follow BTS guidelines, and the most updated ones say that LABA is third line. Just something to note. They said last year for us that it's not likely to be tested on due to the fact that it's quite a recent change. I don't know if this is still the case, and because there is differing opinions and different guidelines, like UCL don't like to trip students up, obviously, but it's just something to note in the case that it does come up, or if things have changed and UCL would want to like start introducing this a bit more, that LABA would actually be third line. But for the most part, they kind of ask up to second line and not much further than that. So don't get too bogged down by that, but just something to note and have a look at if you want. Yeah, I'm just going to go back to we'd really appreciate your feedback, guys, as well. Does anyone have any questions? You can just pop those in the chat as well. Anything that wasn't clear that we can try and clarify.
I have a question on, can you hear me?
Yes, we can hear you.
When you have a middle lobe collapse in the right lung, do you automatically get like a lower lobe collapse too? Like on that slide?
Not necessarily. Yeah, I was actually thinking that question might come up.
I think it was the one before.
Yeah.
Yeah.
I think It's just because of the collapse, I assume everything sort of shifts. Like when you have any lobe collapse, like everything in the thorax kind of shifts a bit.
Yeah.
So I think maybe there's just been like a little bit of a shift, but I don't think there's a collapse. As you can see, there's like a somewhat maintained like lobe here.
Okay.
So yeah, I don't think that would.
I think because the airway, like airways are like quite distinct in that way, and that's why like the right side has those 3 lobes. So even though like they're so close together and obviously interconnected, they kind of have their own airway supply. So actually, yeah, the right lower lobe, I think, can like continue to do its thing. Of course, you could have both collapsing, but it's very possible to only have one part of it collapsing.
Okay, because is it the middle and upper or the middle and lower lungs that have the same, like the same kind of, like after the bifurcation at the carina, there's the kind of like 2 bifurcations in the right lung, and then one of the bronchi divides into 2. And I can't remember, is it the right, middle, and lower that are supplied by the intermediate? I'm not sure if that has anything to do with it, but I'm not sure if I'm making sense.
Let me get a diagram up.
I think it might be lower and upper actually. I'm not too sure about that, but
No, I think I see what you mean. So as in,
I do see
you're
what you
saying,
mean.
yeah,
Yeah.
where the right lungs, then you've got like a large vessel that then goes into sort of the middle and lower lobe. So yeah, so that's like more closely connected. But again, like they have so many other smaller vessels that can still, it's possible to keep one side open, but the
Okay.
other one kind of not existing.
Okay. Okay, thank you.